Good morning, 6:30. We're going to go ahead and get started with grand rounds today. It's vascular grand rounds. Just a quick reminder, next month is our ethics conference. So if you haven't registered, please register for that. And then today is vascular grand rounds, and we'll have Dr. Singh come up and introduce Dr. Brooke.
Thank you, Dr. Inaba. It's with great pleasure that I get to introduce a friend, a personal friend, but a friend of our division. And it's somebody who's coming from around the corner. And I just realized this morning that Dr. Peterson went to the same junior high school in Utah. So it's like a small world after all, right? And Dr. Brooke comes to us from the University of Utah, where he's the division chief. He went to the University of Virginia for undergrad, and then back to Utah for medical school. He then embarked on a long time at Hopkins, where he did a surgical training, but also was a postdoctorate fellow and did his PhD while at Hopkins. You don't hear that too often. So he spent a lot of time there and did a lot of research on outcomes, surgical outcomes, and then went to Dartmouth and then subsequently returned to Utah, where he's now, as I said, the division chief. Dr. Brooke is prolific in publications. He has 180 publications. He's got funding from NIH, from the VA, and he's an associate editor of the Journal of Vascular Surgery. He is a very humble person, and he does great work. And as I said, I'm interested to hear about the digital surgeon, and welcome Ben to the grand rounds.
Thank you, Dr. Singh, and just the Division of Vascular Surgery at University of Washington. It's very honored to be here, and the Division of Vascular Surgery at UW is considered one of the best within our vascular surgery community, and so it's a privilege to spend time here and just kind of learn from how they're doing things, and I always find this is a valuable opportunity to learn how we can also adopt some of the things you're doing. But today I wanted to talk about a topic that I think is very timely: digital health. This is something that in surgery, I think is something that we're now evolving and learning about how to adopt it in our current workplace. But I want to talk about where we are now, but also where the future might hold. So my disclosures include I have a VA grant that's based on telehealth, so that's one of my financial disclosures. But I've been on the ACS committees for telehealth and AI, so this is also something that we're talking about some of the policies that are related to AI. But I do not have any disclosures relative to any companies or technology that I'm going to be talking about today. So the objectives of this talk are to talk about how remote care using digital health can be used to eliminate geographic barriers of care, review some of the different technologies that can be applied, and then just detail some of the steps how digital health can be implemented into routine surgical practice. So geographic barriers to surgical care are well known and really exist across the spectrum of different surgical specialties. There's more than twice as many surgeons per capita in urban as relative to urban areas in the U.S. And this gap continues to widen, particularly for specialties such as vascular surgery. And that's why, as a vascular surgeon in Utah, a lot of my time is spent trying to address getting patients from rural areas into, see us. And one of the things that we've done in Utah is we've set up outreach clinics in different rural areas. So on any given month, I'm going on a university plane to fly to one of these different outreach clinics that we've set up in rural Nevada, Wyoming, and Utah. And we don't do any of the surgeries at these outlying communities, but we do see all the patients during their pre-op and post-operative care. So a lot of this referral pattern, and seeing a lot of referral from rural patients really is established because our health system is set up this very kind of robust affiliated network of hospitals from all these different rural areas in the surrounding 5 states around Utah. So, it's fair to say that nearly half my patients that I see on any given month are from a different state and have to travel hundreds of miles to see us for their surgery. This is really not probably a unique thing for the people in this room, because you guys exist within the WAMI region, and it's really kind of in a very similar in terms of the scope of geography, but also the practice patterns you also deal with, having to deal with a lot of remote surgical care. But when our patients are distributed this far away from us, I mean, it really kind of compounds and exacerbates a lot of the common challenges that we deal with in surgery. the frequent need for wound checks, exams, imaging, and monitoring after patients undergo surgery. High readmission rates for patients undergoing complex surgical procedures. And when they live hundreds of miles away, like getting them back to our hospitals is a challenge. And then the disparities in access for surgical care for patients that are older, from lower socioeconomic backgrounds, when they have to come in, or when they live in the rural areas and they come in for surgery. A lot of these challenges in rural health care really being challenged and even further limited based on the fact that a lot of these rural hospitals are really financially challenged right now, and that's only getting worse with the passage of this big beautiful bill that is really putting a lot of like restrictions on Medicaid funding, and really there's going to be a lot of hospitals in the next couple of years that are at risk of closing. So I think when we think about these challenges in rural healthcare, we really have to think about how surgical care is going to be delivered. And what I would sort of argue through this talk is that we really need to be accepting and thinking about this paradigm shift in how we adopt the spectrum of digital health technologies and how we can apply these to the delivery of remote care for a surgical patient. So digital health is a broad term, and it encompasses a lot of different technologies such as telemedicine, telehealth. There's wearables, there's sensors, there's mobile phone apps. There's apps that are integrate with their electronic medical records, but it essentially allows us to communicate with our patients remotely. And we all sort of, I think, know about digital health. I mean, it's not a new concept, but it's really kind of come to the forefront because of the emergence of AI and what AI can do to, combine with digital health technology, and it really allow us to, have very powerful, tools that allow us to, deliver remote care. So these are, digital health and AI are things that I think really are disruptive technologies that doesn't matter how old school and conservative, a lot of, surgeons are. I mean, you really have to be thinking about how this technology is going to be disruptive and needs to be integrated within how we deliver surgical care. So, again, my talk is really talking about how we can deliver remote care using a lot of this technology and break down these geographic barriers of care. But I think there's three kind of main areas that we can focus on right now, and that's telehealth, the mobile health applications or smartphone apps, and then the wearable technology. So, talk about some of these things and how they integrate within an episode of surgical care. There's already things that can be integrated, but I think for the people in this room, we just have to say, like, are surgeons going to adopt these tools? I mean, this is forward thinking, but like, are we ready to go forward with this? As we all know, surgery is a contact sport. Before we do big invasive surgeries, we like to lay our hands on patients. We like to have direct, face-to-face communication, both in the pre-op and the post-operative period. And that's, just sort of intuitive in how we deliver care. But, as we all know, like 6 years ago, the COVID-19 pandemic really changed the way that we think about how we can deliver remote care. And with social distancing, a lot of us really, most of the care we delivered for that period of time was done remotely. And after that, we kind of realized that, hey, we can do this. So, whereas during COVID, almost 50% of our care was delivered remotely or virtually. Over the last 5 to 6 years, I mean, it's really kind of settled out to about 15% of our patients are still, we're seeing them, before surgery, after surgery, using a telemedicine or telehealth appointment. And what we found also is that, through a lot of data that was collected during this time, that, we can safely, deliver care remotely. A lot of the outcomes amongst patients that were cared for during this time, we found that, they didn't have like adverse outcomes, or there wasn't like sort of something that happened that was like directly related to just seeing them remotely. The other things that have changed over time is that we're now getting reimbursed for these remote telehealth visits. It used to be that only patients that came from rural communities you could get reimbursed for doing a televisit. But since COVID, Congress has passed these consecutive legislations and acts that have allowed us to get reimbursed. And most recently, in February of 2026, they passed a 2-year extension. So we can continue as long as we're doing a virtual, like a video visit with one of our patients, we will get reimbursed. and that's true for surgical patients. The other thing is that, there's really been kind of a thing that supported the delivery of telehealth. It's really, the expansion of high-speed internet coverage and broadband across the continental U.S. I mean, as you can see, like actually in the Western U.S. where we're located, they actually have some of the highest rates of broadband coverage. So, we can connect with our patients even if they live in these rural areas. And kind of surprising that to see that a lot of the patients that live in the Midwest and the Southeast have the worst internet coverage. I would have expected that to be different, but things might also change just with the emergence of the 6G internet and broadband coverage over the next couple of years. I mean, that's going to essentially increase the download speeds almost about 1,000-fold over existing cell phone technology. So I mean, this is also going to be something that's going to be pretty powerful. I mean, the other thing that's going to it's changed is that we've really kind of spent a lot of time over the last couple of years really focusing on telehealth and how we can apply it to surgical delivery. So we've spent time developing and implementing some of the quality standards for surgical telehealth, and this is a paper that the ACS committee that Dr. Singh was also on that developed some standards based on this Donomedian model for looking at the structure, the process, and outcomes to ensure that if we are delivering telehealth, that we have the kind of the quality infrastructure within our hospitals to make sure that we don't have adverse outcomes. So based on a lot of this this new technology, I think in the year 2026, we're all fairly comfortable having a remote televisit with one of our patients as long as we got our laptop and we've got a good solid connection to the internet. It doesn't matter where we're located. We could be anywhere in the world and still be able to deliver some sort of remote telecommunication with that patient. But the question is, I mean, we're kind of doing this on an intermittent basis right now, but can we move to doing this on a more routine perioperative pathways where we're doing routine preoperative and postoperative care delivery? So that's something that I've been thinking a lot about, and I wanted to kind of give an example of a program that I've been involved with at the Salt Lake City VA over the last decade called the Transitional Pain Service. So this was a program that we set up to basically as a perioperative surgical home model to identify patients that were at high risk for opioid abuse and addiction. So identifying veterans that had like mental health and different comorbidities that sort of like predict whether you're addicted to opioids after surgery. So this is a model that was based on basically identifying veterans early on, doing preoperative education like in person, setting up like very patient focused or individual care plans, and then follow them very closely during the hospital admission and postoperative period, and then actually following them out over a year period and doing like warm handoffs to their primary care doctors. All these patients see basically a pain therapist to do cognitive behavioral therapy, and so it's a very intense program, but it's all very based on having in-person care. We also developed these dashboards for patients so that any provider involved in their care, whether it be the surgical team or the PCP, could be like seeing exactly what their pain therapy was and modalities, and if they were on opioids, like how it was being tapered and like what other sort of modalities were being used for pain control. So this was something that was set up. And what we found is like after doing this program and setting it up, we had a fairly dramatic, like profound reduction in opioid use. So veterans that came in that were opioid naive, like historically have about a 5% or 5 to 8% chance of becoming like chronic opioid users, just because surgery is a gateway for opioid exposure. But after implementing this program, we found that basically over the last 6 to 8 years, we've had almost like no opioid use whatsoever. Anybody who is opioid naive. We also found that people who were on chronic opioids before surgery were able to almost like reduce their opioid use by half. So very successful program. Published a lot of papers on this program, and essentially found that it's a very effective way for preventing new chronic opioid use, but also improving quality of life and patient-reported outcomes. So again, we were very happy with this program, but something happened during this time that also has kind of influenced how we deliver care. So the VA Community Care Program was started based on legislation that was passed back in 2014 and 19 Choice Act and the Mission Act to basically, identify veterans that lived in rural communities to say, hey, if there's a problem getting access to certain, more, specialized surgical care, we're going to allow you to go see surgeons in your local community. So this legislation has really kind of expanded, the access for veterans to go to like a lot of these rural hospitals, reduce their wait times. And right now, like based on like, the most current numbers, I mean, almost 30 to 40% of veterans are now getting their care outside the VA. They're not going to, traveling 100 miles to maybe their most tertiary level VA, but they're just going to the local hospitals. But what's happened with that is that, when veterans are going through this community care program, a lot of the things that we kind of were, suspecting was going to happen, we found this happen. And we published this paper last year showing that, rural veterans who go to these non-VA hospitals, they actually have a much higher rate of having these risk factors for opioid abuse. Because if you think about it, they're being seen by other surgeons. They're probably just getting like a lot of opioids. They're being told to like go back to their PCPs at the VA, but it's really kind of exacerbating a lot of these problems that we were trying to treat with the TPS program. We also found that there's just a lot of fragmentation of the care delivery and the care coordination between the VA and non-VA providers. So, after collecting some of the data on this, we were wondering how do we address some of these issues that are happening with this VA community care program. And really the solution was to think about how we could, package all these components of a TPS program into a telehealth delivery for these veterans. So we did this pilot study a couple of years ago, and we got funding through a grant through the Office of VA Rural Health. And this is the kind of a map of the referral region for the Salt Lake City VA. It's a fairly rural part of the Intermountain West, where you have patients coming down from Idaho, rural Nevada, southern Utah, which is very rural. But we identified patients that were referred to this community care program for surgery. And then we basically implemented a telehealth program to follow these patients, preoperative, after their hospitalization, and then for a year afterwards, and then did a mixed methods analysis. And what we basically found is that from our data that the telehealth TPS approach can essentially replicate what we were doing in person. We're able to prevent any new opioid use, and then after doing these interviews with the vets and as well as their providers, we found that this was a very effective way to provide remote care, and both in the pre-op and the post-operative period, and really address a lot of the things that we thought only could be delivered in person, could definitely be delivered remotely and through this telehealth delivery system. So based on this pilot study, we just a couple of years ago launched this randomized controlled trial that's being supported by a VA Merit grant, where we're randomizing patients who are referred for this community care to a telehealth care coordination intervention arm. And then that's compared to just, standard care delivery, where they're just seeing their surgeons in the community, and then, ultimately, following up with their VA PCP. So, the outcomes of the study are to look at, opioid use, but also just healthcare utilization, and then patient-reported outcomes. And we're following patients, from 90 days up to a year after their surgery. Right now, we've randomized about 2/3 of our enrollment goal, and so we're on track, and hopefully we'll complete enrollment the next year and be able to really kind of have some level 1 evidence to know whether this is a good way to support care delivery. So again, this is an example of how we can deliver telehealth remotely, pre-op and post-op. And I think the other areas that are really kind of important right now is to look at the mobile health apps and the wearables. So let's talk about the mobile health technology world. So this has really kind of exploded over the last couple of years, and it's not surprising because nearly 93% of U.S. adults have a smartphone. So we have this technology, we have these apps on our phone existingly. And if you look at just the number of mobile health applications that are available on the market, I mean, it's really just exponentially increased, and really there's apps for pretty much everything you can imagine that are related to health and surveillance, and just being able to communicate with providers or get new information. This is also existing in surgery. There's a lot of apps that are allowing us to communicate with providers to be able to reach out to our patients to make real life, kind of real time surgical decision making without, being there, like face to face with our patients. So here's an example of some of the different, apps that are available on the market. And again, this is not inclusive, but just kind of some examples. So Seamless MD is an app that allows you to, send pre-op instructions to your patients, but also, follow them after surgery, like for instructions and for education and for, different follow, surveillance. There's apps Draw MD that allows you to, kind of do schematics and illustrations of like, what you're planning on doing for your surgical approach, or, things that they might need to, you might need to give them some like illustrations. There's a lot of apps are out there for, following up wounds, doing, follow-up care, be able to look at wounds, be able to, patients to send their wounds through like, HIPAA compliant, platforms. And then there's apps that allow us to, sync up with like AI technology, like Viz AI, where, this allows us to basically, if there's integrate with our PACS systems, our CT scanner, so that if there's a specific, a diagnosis like an aortic aneurysm, it will automatically flag you and send, basically a text message on your app to say, there's a patient in your emergency room that just got scanned that's got a 6 centimeter AAA. So this is something where I think is really kind of where a lot of the future of app technology is going to be is integrating with AI. I mean, there's other AI powered tools like such as this app that was developed for remote wound management, where basically you can scan a wound photo into your app. The patient sends it to you, but it also basically analyzes that wound to tell you like, is this a wound that is at risk for, basically, not healing? Is, where is it in the wound trajectory? But also giving recommendations for management that can be done based on, AI sort of wound image software. But the other thing with AI technology is it integrates with apps is it really it's developing apps is becoming a lot easier. So, several years ago, we set out to develop an app for patients with peripheral arterial disease. So one of the graduate students was working with me. We collaborated with Dr. Oliver Alami, who's a vascular surgeon at Stanford, who also runs the Biodesigns for Digital Health course. And essentially we said, hey, we want to build an app that's developed for patients with claudication, because we want to be able to follow them with daily step counts. We want to be able to administer patient-reported outcomes, and then also do deliver instruction for doing like assessments of their mobility and physical function. So we built this app. It's publicly available. Only took about 3 to 6 months to get sort of completed, and we've been able to now offer this to our patients. They can download it. And, really, once you start doing these things, you realize that there's just so much information you can gather from your patients remotely, any given day, any given second. And it's sometimes like a little bit of information overload, but I think this also is pretty powerful. It's also becoming more relevant as when you think about all the different, wearable, sensors and the technology that, is available for patients. I mean, there's essentially, all sorts of like, wearables, whether it be clothing or watches that, patients can wear. That's going to be able to gather information about, their environment, their mobility, the physiology. I mean, there's wearables right now that, basically you can put your thumbs on and like, it will analyze and do an EKG, for you. Or there's wearables that you can stick on your leg and your arm and calculate an ankle brachial index. I mean, these are like pretty powerful technologies that are not maybe commonplace, but they exist, and it's just a matter of how they develop over time. So how does this, work? I mean, a lot of times, somebody's got one of these smart watches. It allows you to sort of like, analyze motion. You combine it with AI, and it's able to, provide a real-time sort of data visualization and remote patient monitoring system that is able to, detect, if the, patient's not able to, like sort of, meet their goals of care after surgery, or if there's maybe, something that it can detect, like some deterioration, like in their recovery before it happens. So there's, the question is, how does this apply to, surgical patients? Well, there was a randomized trial that was just published recently where, they randomized nearly 300 patients that were undergoing surgery for a cancer diagnosis, abdominal surgery, to getting telemonitoring versus just, routine, like, care. So kind of a pragmatic trial, but the telemonitoring consisted of one of these, smart watches that was able to, connect with one of these remote, platforms. So if the patients weren't, sort of, getting up and ambulating after their surgery, if they weren't like sort of, meeting some of these goals that we set for our patients, the surgical team or a nurse could basically contact the patient and like give them instructions and like sort of give, feedback about how to sort of increase their mobility. So what they found in this trial is that, patients that were getting this remote telemonitoring had a significant faster recovery with improved motility and fewer symptoms by day 14, and it's extended up to 90 days after surgery. So pretty powerful. And I think, this is just kind of like the first trial of this sort of platform that, but I think there's going to be a lot more of this coming out on the market. So, this is kind of an example of how, technology can be used to monitor our patients, before and after surgery. But the other question is, can we also use digital health and AI in the operating room? Like, what are the potentials for how we can, apply this technology? So I think one of the things that is like kind of most fascinating to me is the concept of surgical telemonitoring. So this is kind of like the concept of, surgical coaching, but, can we do this remotely? So there's now, technology that allows us to basically do two-way communication between a surgeon that's, in an operating room, maybe in a rural hospital, and somebody who's more experienced that can guide them through a surgery that is enabled through, these platforms allow what they call telestration, where you basically can annotate things on the screen and like show, a surgeon who's in a different location, like anatomy, point out things that might be critical, some things that maybe they're not familiar with. And just the ability for this to be utilized in a way to provide, remote, surgical care, I think is pretty profound. There's already a bunch of studies that have been done looking at, how this can be applied in rural and low resource settings, and the data is there. Like it's showing that these are platforms that are really kind of valuable, and it's just a matter of like as they, kind of build and the technology becomes more accessible to us, how we can apply it in like our own surgical practices. So I got kind of interested in this because a couple of years ago I was asked to collaborate with a hospital in Rwanda who was looking to set up a vascular surgery kind of training program. So, I was like, Rwanda. So I go to Rwanda and I find out, it's a country of 15 million people. They have no vascular surgeons, but there's a lot of vascular disease in Rwanda, surprisingly. And, when I went there, it was trying to figure out, okay, they want to set up a training program. How do we do this? Well, took me like, a day of travel just to get there. And then you're, jet lagged, and you're like, okay, can we set up a program to do this global surgery sort of collaboration and like teach them how to do vascular surgery, and how is this going to be sustainable? Well, it's kind of hard to do this. I mean, we all know, like anybody who's done a sort of global surgery sort of initiative, it's just the time and resources to sustain these programs. I mean, we can all like fly over to Africa to, collaborate, but like doing that on a sort of ongoing, month to month or yearly basis is just very challenging. So, so identify, what we needed to do in this program was we needed to teach them how to do like AV fistula. I mean, that was like the easiest way to say, okay, this is how you do a vascular anastomosis, and we'll teach you how to make an AV fistula, because nobody knew how to make an AV fistula. I mean, there were a lot of general surgeons, they know how to operate, but they didn't know how to do a vascular anastomosis. So we're setting a program where we're going to go in person, do one course, teach them, some of these basic skills, but then set up a telemonitoring mentoring program for them, to sustain through their learning, so that it's not just like a one and done, but we're actually like, having to set up these meetings so that they can actually do surgery, we can be there and kind of point out the things that, are going to help them, become very proficient and comfortable with their vascular surgery skills. So, this is pretty exciting. The other areas, of I think digital health in the OR. I mean, unfortunately, vascular surgery doesn't do a lot in, robotic, surgery, but, the next kind of thing in digital health in the operating room is really like anything that can be done robotically, in theory, can be done in a remote, sort of telehealth platform. So, telesurgery is essentially, having a robot, setting up a very, secure communication platform and having like a remote, sort of site where you could, do a remote surgery robotically. So, there was just recently an FDA approved telesurgery clinical trial that was launched, and this was the first operation that was done by a urologist that was in Florida that did a surgery 7,000 miles away in Africa, did a radical prostatectomy and it did fine, and like the patient recovered fine. And again, this is part of an FDA approved telesurgery trial that's it's going to be kind of exciting to see like how this unfolds and just the application of this sort of technology moving forward. Obviously, like a lot of people are like throwing out like, where's the surgery, the future surgery look if we have these robots or we have AI that's controlling these surgical robots or humanoids. What is the potential for how this technology can be used in the future? It's amazing that anything that can be done robotically, if you think about it, like the Da Vinci robots, they basically create videos of all the different surgeries, and so you feed those into systems that are it's AI technology that can learn from those robots. There's now like data to show that these robots that watch surgery on videos can now like actually replicate these skills. So this is not just kind of the sci-fi sort of like, hey, can we do this? It's actually being done. And the next kind of application of this is can you create these humanoid robots that are actually able to be controlled by humans and but done in sort of a remote setting. So just last year, there was one of these also experiments where there was a humanoid robot that was controlled, remotely, both using like humans and AI, but was able to take a gallbladder out of a pig. So, again, we're obviously very early in this evolution of technology, but it's there. It's not just something that is kind of something that's too far away in the future if we think about where this is going to evolve. So. I think the thing that we have to think about right now is adopting digital health management to surgical care. Where do we go forward? I mean, there's a lot of the technologies are existing, but we have to be thinking now about the ethics of using digital health and AI. How do you do this like within a legal framework, within an ethical framework, and what's the governance of this? I mean, if you have some AI guided humanoid robot that's doing surgery, if there's a complication, who gets sued? Like, what are the ramifications of if there's complications or something goes wrong? So again, I think we have to be circumspect and we have to kind of put the brakes a little bit on how we rush into this. But a lot of the AMA and the American College of Surgery is really they're trying to focus on developing some governance for this, and there's been some white papers that are starting to come out and thinking about the steps to how we can do this. The other thing I think is important to sort of talk about is just developing sort of the equity and how digital health and AI is being sort of given to our patients, because if you think about it, if only the people who have money and resources get access to this technology, it's not really going to allow us to sort of be able to do this in like a systematic approach. So being thoughtful about how we also develop equity within the delivery of these care systems, I think is really important. So again, adopting AI into your own surgical practice, I think we have to be careful. We have to be circumspect, but we also start having to think about how it's going to be done. So my own sort of like practical checklist for implementation of digital health and AI is to first just assess like how ready your organization or your vision or your group is for this technology. I mean, there's a lot of things that are available, but are people ready to use them? I think you have to engage the end users, which are the surgeons. Are they actually going to use it? And help. I mean, like I get together our teams and say, like, what do you think about this? Like, I just learned about this new app or this wearable. Like, did you ever use this? And if you don't get end user buy-in, like you're not really going to be able to get the stuff implemented. I think it's important to really also focus on workflow, not just the technology. I mean, there's a lot of cool technology, but if it doesn't actually fit into your workflow, you need to prioritize the tools to solve a surgical problem, and hopefully integrate within our EHRs. If you're collecting a lot of data you can't get it into the patient's medical record. Like it's really kind of clunky. And what I find that, it's if you have two separate like platforms where you're collecting data, if they're not, integrated, then it's also creating like a disservice just because it's potentially creating a lot of extra workload. I think it's also important to build the digital literacy within our teams, just, making people feel more comfortable with using this technology. Having like a digital health champion within, your groups, or teams, just to help kind of identify new things that are coming out and be the ones to kind of like do some of the early pilot testing. And then ultimately with any sort of implementation, you have to have a kind of a feedback loop. So it's not just like you're implementing something and not kind of thinking about, does it need to be refined? Maybe it's not going to work if we have to sort of, nix, some sort of new technology. So, this continuous feedback for evaluation and refinement is, I think, a very important thing that we need to think about. So how does this all come together? I mean, what I like to think about is, what's an episode of surgical care look like, for anybody in this room? I mean, this is, I'm a vascular surgeon. So, here's my current, workflow for a patient undergoing a femoral popliteal bypass. Doing like inpatient care for their pre-op. I'm obviously there for their surgery, their hospitalization. They might stay a week in the hospital. We're having, all these kind of in-person follow-up visits, annual visits for the imaging. And then, if they have a complication, they're calling and they're coming back to the emergency room for triage. And, we have to decide like what if they go back to the operating room or figure out what the next steps. But let's think forward, maybe 15 years from now. Like what is a potential future episode of remote surgical care if we have all this technology that I'm talking about and it's able to be applied to, how we deliver care for surgical patients. So in the pre-op, we could have a video telehealth consult. We're not seeing them in person. Intra-op, I mean, there's a potential for doing either a telemonitor in case the patient doesn't live, in like a rural or remote community, or maybe, there's the potential to do remote surgery using a robot. I mean, I think it's going to be hard to do that for a bypass, but, again, like anything that can be done with a robot potentially could be done remotely. Hospitalization, I think there's potential, using a lot of wearable technology that, we can discharge patients a lot earlier than we do currently. I mean, with wearable monitoring, it allows us to determine if there is something going on that's not part of like kind of routine, like post-operative, like patterns of recovery. So we can identify things early and determine if they're going off like our normal pathways. Short-term follow-up can be done, again, remotely, video visits, instead of having them come back for, imaging in person, like just having wearable technology that allows us to calculate an API. I mean, that's certainly something that I think is going to be available in the next 10 years. And then long-term surveillance, doing bypass graft sensors with AI interpretation. Again, do we have to like be doing arterial duplexes in all of our patients, or can we have, wearable monitors that are able to do this? And then finally, again, automated technology allowing us to determine like, is there, a complication that can be triaged without having the patient have to come all the way back to our emergency rooms. I mean, can this be triaged, or can we, use telehealth or AI to make some of these decision makings and do things without having that be in person. So, again, I think there's a lot of potential for this technology. So in summary, I think there's many aspects of surgical care in the future that is going to be delivered remotely, whether we like it or not. And, being able to kind of look at all the options for digital health and AI, and being able to think about, what's available now, but also what's potentially going to be available in the future is important. Ultimately, this is going to help break down a lot of the geographic and socioeconomic barriers to surgical care. I think we need to start with like what's available right now. I mean, there's, obviously telehealth, smartphone apps and wearables. We all have, access to those right now. And I think we should be thinking about how they can be used. As I mentioned before, I mean, equity has to be built into these programs. Otherwise, we're going to widen the existing disparities if some patients don't have access to this, but patients with resources do. And then also, the final take home is that I think, surgeons need to lead this digital health transformation. We shouldn't be waiting for our medicine colleagues to sort of, tell us what they're doing, but we should actually be thinking about what technology we should be incorporating into our practices. being the one who wants to kind of lead this future of digital health and AI. So anyhow, I really appreciate the opportunity to kind of talk about some of these concepts of technology, and happy to be here to answer any questions and just kind of further this discussion. So.
Sorry. Yeah. As we move forward into this future, there's going to be a lot of things thrown at us. I mean, is there going to be groups that look at this and figure out which one we should be using? Like you said, our institutions will tell us what we can and can't use, but there's also places that just aren't going to do this, right? You and I were talking recently about somebody went into practice in Nevada who didn't have access to an ABI machine, so they didn't do ABIs. So how does this get disseminated broadly so that it's not just centered in like an academic center or a big city kind of setting?
Well, that's the big concern right now in terms of the, like I said, the equity to access to this technology. And I think a lot of this technology hopefully will be found very affordable. And so, it's not going to be something where you're going to only have to be at an academic institution that actually has the money and the resources to purchase it. But it could be something that, even like patients, that have very limited resources can get access to. It's kind of like if you think about, where was having a cell phone 25 years ago. I mean, it was one of those things where only a few people had a smartphone. Like Apple, the Apple iPhone came out, only a few people had it. Now, look at it. I mean, everybody has it. Even people who live in, remote third world countries have a smartphone. So I think the dissemination of technology, it's one of those things where early on things are going to be expensive, and maybe it's going to be trying to figure out what can we do that's going to be affordable and sustainable. But ultimately, I think over time, a lot of this technology is going to be something that we figure out a way to just make very it can be disseminated within a very broad range of our population, and not just kind of for the few and far between.
You mentioned wearable technologies to monitor things. Are there any implantable technologies that maybe within an endograft can monitor flow and say, hey, quick, the graft's about to go down, take an aspirin and call the surgeon?
Well, I know there's actually a whole device, and there was a company that reached out to us about monitoring a sensor, right over their official to determine the flow rate. And so I know that's able to be done, but you could also do that for a bypass. I mean, if we sort of have ways of identifying, changes in waveforms and bypasses, or, obviously increased flow velocity. So why can't that be just, you can just slap some sort of sensor on somebody's leg after you do their bypass and just keep it on them for, the first, month, or even longer. I mean, I think honestly, a lot of this technology it's there, but it's just a matter of people really kind of thinking about how to make this commonplace and make surgeons say, hey, I'm happy to look at the data from one of these sensors and not have to have my patient come back to my clinic, for surveillance.
Great talk. I wonder if you can comment on the discussion within ACS or AMA about kind of overcoming the logistics and the challenges of medical licensure. Because with all the telemedicine, we have patients from all of these states, and to do this legally, technically, we need to have a license that gets renewed every year in all of these states. Is there a push at the higher level to try to overcome that barrier?
That's a good point, and I know that's something that we're all struggling with if you're to get reimbursed for it sort of out of state, television, you still have to have a license in those state. I mean, I don't know if you guys use the interstate compact, but I know that in Utah, I have licenses in the surrounding 5 states just because they've made it very easy to get. If you've got a medical license in one state, I mean, I think nearly like 45 out of the 50 states now are part of this interstate compact, so that you can, basically, if you've got an existing license, it's very easy to get another state's license. It used to be, I remember, like, for example, Nevada was like one of those states where they made you go through like a lot of like, letters to get a medical license. You had to go to CME, and it was just very kind of like labor intensive. But now, like, our partners, when they join our practice, like, I give them, to get my medical licenses in all the surrounding states, and it's actually very easy now. So I think I think it has become a little easier to do that, and to sort of address that issue of, getting reimbursed for this business.
Ben, thanks so much. This is a really great talk, and I appreciate your coming and sharing it with us. I have two kind of questions, and one is about regionalization, the other is about payment. So I think, this for our BTVAR practice, for example, has been really helpful in terms of augmenting the regionalization of that care, I think, in a lot of ways. I guess I'm curious if there's any, again, from the sort of ACS perspective, what does that look like? Is there thought about that in terms of, both being able to provide some of this care remotely, but also actually facilitating regionalization for complex care, which I think is sort of an important part of this. And the second that goes along with kind of what we've been asking you and what you've been talking about is, the reimbursement. So for BTVAR, for example, it's actually cost neutral for us to do a BTVAR, but the hospital makes money when the patient comes back for all their CT scans, right? When they never come back for a CT scan, it ends up just being like we lose $5,000 for doing a BTVAR. But if we get 5 years with 7 CT scans, we end up actually kind of coming out a little bit in the black. And I guess my question for you is there any kind of, again, anticipating or thinking about what that's going to look like, right? Because I think we're going to have some higher level for this to work. We have to have a higher level of cross system integration. And with that has to come some financial risk or reward. And it can't just be unidirectional, and I guess I just don't know if that's a thought, again, at sort of ACS level, or if when you've thought a lot more about this than I have, how you guys are thinking about that. Thanks.
Yeah, man, bring up some good points. I mean, the way the complex, vascular is something that, obviously very heavily debated because, trying to tell, some surgeon who works in some smaller community hospital who feels like he can do these cases, like, trying to tell them he can't, like, it's not something I think where ACS has that ability to implement those kind of things. I think that has to, at a hospital level, if they can't sort of safely, deliver care for complex, patients, and do they have the ICUs and have the ancillary services to sort of manage this patient? I think it's going to be hard for like a governing body like ACS to sort of think how that's done, but I think it's going to be something that is more done like along the lines where people just realize that, they're going to get better, outcome from their patient that they're referring to you versus, some guy in the local community that says he can do it, but be far, but maybe like it's probably not the patient's best interest. But these are obviously like conversations that you all have and kind of they're debated, but and it applies to all surgical specialties. Case examples where you all say there should be, regionalization of these procedures. In terms of like the reimbursement, I mean that's also like you bring up a good point because, I mean, that's a very valid like way to think about, what's the hospital. Are they really recouping a lot of the technical like revenue from our cases? That's obviously important, but the way I think about it is, we get in there for the surgery, maybe they spend like a week in the hospital. They recoup a lot of the costs. Maybe it's cost neutral, but I don't mind having my patients get all their CT scans remotely as long as I'm able to follow and as long as I can get manual surveillance. And to be honest with you, like, I mean, from the wider level, it's not something that I'm like focus on, but you're absolutely right. Like the hospitals might start cracking down on that and saying, hey, we need some way of like being to capture a lot of this, this revenue that's being lost just from imaging, which is obviously one of the big ways of kind of making these cases not just, a loss that, a positive. So, but that's a good thought. I don't know if there's like a solution to this just right now. Like, it's not something that I'm sort of, I'm not willing to sacrifice, trying to get the patient back, and live in Nevada to the proceedings in Utah. So.
Thank you so much. And amazing presentation. I have one question about these remote clinics that you're traveling, and I want to know about education. Are you bringing your residents? How do you get them involved, and what are the logistics on keeping them with this opportunity?
Currently I don't bring any residents or fellows just because I feel like it's, they're always like doing cases, or it's kind of like asking them to do, it's a full day of travel. They like go back or come back. I do take a medical assistant, and a lot of these clinics we do are, we're not just doing them like solo, like for example, the first Tuesday or not that I fly with the dermatology group that goes to the same clinic in Nevada, for example. And they actually do bring all their residents in that sense. It's like they've got like 6 people that like travel with. I'm just kind of like, I travel a little here, and I just find that it's a little easier to do that. But it's funny. For all of our clinics that we do, we have a vascular lab tech that comes with us. But I'm very comfortable flying on these small planes. Our vascular lab techs are not, so they'll leave the night before and like stay in these towns and then like come and do clinics with me. And then they'll drive back because they just don't want to fly on the planes. And I was going to have to convince them that, you have a greater chance of getting in a car accident, like driving, hundreds of miles to these clinics versus in a plane accident. But, they just, they're not going to listen to me.
So I love the idea of all like from a conceptual standpoint, it makes a lot of sense to do all of this, especially like with WAMI, and we're seeing patients all over as well. I was wondering, and I saw like the research and the pain clinic support, but I was wondering which of the devices you've implemented in your own clinic, and then like how is that being managed at a clinic level with all these alerts? Like, are they going to you on 5 different apps on your phone? Are they being integrated into like your version of MyChart? Like, at what point do you get notified? Like, who's managing all of these alerts from?
It's a great question. And I think we're all susceptible to information overload. It's like, we have all this access to information, but like, how can we actually like, organize it and make it so sort of usable and sustainable? So I think there's several things that I use. So in my own individual clinic, I mean, if I think about like the apps that I use in the AI technology, so I use an AI app for ambulance listening technology. So when I'm doing a clinic, it's we use a bridge. So I basically walk into a patient's room. I can tape record the conversation, and then it will automatically synchronize or integrate with my Epic node. And I started using that maybe like a year ago, and it was really funky at first, and now it's actually pretty good. It's like it kind of refined the technology. You never like have a polished note when you're done, but you have maybe like 2/3 of a note that you can add like a little bit of information, but it really saves a lot of time. I mean, if you're doing a clinic, particularly one of these clinics where I don't have a resident to go with me, like like after a busy outreach clinic, I mean, I have to come home and like spend a couple hours writing notes. Well, now with this technology, it like saves a lot of that time. For the U-Step app, a lot of the information we get from those patient-reported outcomes and like some of the walking tests and the step counts. One of my research nurses actually collects a lot of that data. We're still trying to figure out how to integrate with it in our Epic notes. We don't have that synchronized yet, so it's separate, but I can still look at it. When I see a patient that I know is using the app, when I see them in clinic, I can sort of ask them, hey, because I mean, with patient qualification, our mainstay is like to use supervised exercise therapy. So we're asking like, how often are you walking? Are you meeting the goals of like exercising 30 minutes every 3 days? Like what are you doing? And I can actually correlate, what they're telling me with like the data that they're collecting. And so it's a way to do that, but also to show them we can create these, and it's on like a separate computer app. I can show them graphs of their patient-reported outcomes that they've had over time. So if they're meeting these goals and their patient-reported outcomes are actually like looking better, I can show them that trend, and that's actually a pretty powerful way to kind of give technology and data back to patients to sort of promote their ongoing sort of compliance with the recommendations. So that's one way I use that. And then the third is I do use that app, Viz AI. So that's the app that is based on, you've got to get integrated within your hospital systems. It actually took some time because there's a lot of like legal sort of like wrangling you have to do. But essentially, like if I have an app on my phone, if I'm on call and there's a patient that gets scanned for like some random, and it could be like an NBC that comes in, they get scanned, they just instantly find an aneurysm. Like it'll ping, and I can look at it and say, oh, that's, maybe it's a size like it needs repair. Maybe it's like it's under the threshold for repair, but at least I can then say, maybe they're going to call me, maybe they're not, but I can at least like now give like that to my clinical team and say, put this patient, like reach out, they've got an aneurysm, and you actually follow them. Or alternatively, like if I'm on call and there's a rupture that comes in, I'll see that CT scan before the radiologist has a chance to read it. I can look at it and say, oh shit, well, we got a rupture AAA. Call the OR, call the fellow and say, get the team mobilized. We got to rock and roll. So that's pretty powerful. I mean, when I'm getting that information, well before maybe there's like a 5-minute delay or whatever, but at least you're getting that information like in real time. So that's what I'm currently using.
Hi, my name's Luis. I'm a medical student, third-year medical student here. Thanks for the talk. It's super interesting. But I have a question as it relates to like medical student side, I guess. So I know that residency is where we technically learn like the surgical skills, but sometimes as a medical student, it can feel pretty, especially in a high-tech OR, like pretty passive observational situation. Especially if we lack like the basic digital literacy. So I was wondering if there's been any sort of efforts or push in conjunction with this to like provide any foundational exposure in medical school so that we aren't coming in as just purely passive observers. I guess I was looking at the robot. I'm like, oh no, that robot's taken the medical student job.
A lot of this technology, it's, I see the value for somebody who's already, experienced and trained and use a lot of this technology to improve like the efficiency of the flow. But, when you're in training, like you need that hands-on experience. I know that, a lot of our medical school, and I think also like I've heard that for the residents here, there is a lot of these ambient listening softwares available, write an HMP for you, but they're being restricted for medical students. Like you got to learn how to write an HMP. Like, if you haven't done that, how are you gonna like? If you haven't done it, like doing the old school way, how are you gonna like know how to do it? Like utilizing like AI technology. So AI is at risk of kind of preventing them from all of us from like learning certain essential things that are important for our surgical careers. Since we can't allow it to take away from those educational things that need to be done in person. So that's why I think we're still in this early phase of trying to figure out like, we have this technology, but how is it actually going to be like, incorporated or implemented into, surgical education, surgical workflow, and the things that are going to need to make it sort of sustainable, but not take away from the learning and the education that's critical. So.
Thanks so much, Dr. Brooke. Great talk and great discussion.